Hello there, I'm James Davison. Thank you for the invitation to speak to you today. I apologise that I'm not able to be with you in person for the weekend. Over the next 15 or 20 minutes, we're going to think about monitoring for patients who have asymptomatic adrenoleukodystrophy. So we're going to focus in this talk specifically about X-linked adrenoleukodystrophy and think particularly about how we monitor, how we manage boys who have got the diagnosis but who are asymptomatic, who don't have symptoms, particularly of the brain disease associated with this condition. If we just think through the journey that you might go through with the diagnosis and where does monitoring fit into that whole journey, we start off in the pre-symptomatic phase. So I'm fine, I've no idea there's a problem, but then symptoms may emerge. Something's going on, but we don't know what the problem is. That leads on to some tests and a diagnosis is reached, and now we know what the problem is. And it's at that point that monitoring starts out. So this is watching how your condition is going, looking out for new problems that it might bring. And that's important because that helps us know about when treatment options might need to be considered. And treatment options can be broadly split into two. So we have the symptomatic treatments, things that we can do to help with the issues that your condition is causing. So managing the symptoms, symptomatic treatment, but also thinking about disease modifying treatments, trying to treat the root cause of the problem and changing the trajectory, changing how the condition develops. And that's particularly important when we're again thinking about adrenoleukodystrophy and looking at the brain disease aspects of that. So how do we monitor? NASA with their high-tech space travel systems, it's all about early warning systems, looking for any change in the trajectory of the flight of the spacecraft. And we're doing a very similar thing. We're looking at how your condition is moving on, how the trajectory is going, and also we've got in place some early warning systems, looking at early signs of problems that we might need to step in to do something about. How do we do that monitoring? Well, there will be those clinical assessments, and seeing the professionals in clinic regularly is an important part of that, both the doctors, the physiotherapists, speech and language therapists, and others as well. Part of that assessment will be looking at the reports that you bring of how things are going, evaluating new worries, new concerns, new problems. And the physical examination is also an important part of that clinical assessment. For some conditions like ALD, there are some specific disease scoring systems that are used to evaluate how the condition is affecting you, and they can be an important part of that monitoring process. For some conditions, there might be lab tests, blood tests or urine samples that can be helpful in monitoring whether a condition is getting worse or stable. And in those tests, we look for things that are called biomarkers, so things that we can measure that are going to help us monitor the condition. And for some disorders, that can be important. And then for conditions like the leukodystrophies, where the brain is particularly affected, brain scans, MRI scans are an important part of how we monitor that. And we'll look at that in more detail in a moment. It's helpful just as we think about that journey, just to think a little bit more about how we get to the diagnosis and the different routes that we might get to make the diagnosis. And as we've already said, for many people, a diagnosis is made because of symptoms that have developed. So it's a symptomatic diagnosis. You've developed some problems, that's led on to some tests, and the diagnosis has been made. But for others, the condition or the diagnosis may be made before you have any symptoms, so before any problems have emerged, so a pre-symptomatic diagnosis. And that may be, for example, because of family cascade testing. So somebody else in the family, in the wider family, has been diagnosed with the condition. That's led on to other people in the family having tests and finding that they may also have the diagnosis. For some conditions, in some countries, newborn screening, so having the heel prick blood test at a few days of life, might test for particular conditions and make a diagnosis before symptoms have emerged. For X-linked adrenoleukodystrophy, that's not currently part of the UK newborn screening programme. And it may be an incidental finding. So you're having tests for something completely different, an unrelated problem. For example, having broad genetic testing for something else that has picked up the diagnosis. And those different routes into a diagnosis are important when we think about where we enter that monitoring pathway. So for X-linked adrenal leukodystrophy, symptomatic presentation, it might be that you've had problems with the adrenal gland, an adrenal crisis that's caused you to have initial problems, and that's led on to the tests and the diagnosis. For others, it can be the neurological problem, so either the brain disease or the spinal cord causing problems with mobility and walking and so on that has led on to the diagnosis being made. And of course, as we've said already, pre-symptomatically, you may be picked up through family testing. Some countries are doing newborn screening, as I'm sure will be discussed over the weekend, and as an incidental finding. So that's important to help us frame where we fit in with the monitoring. What do we do in terms of monitoring? Now, there's been a lot of debate and discussion about the best way to make the diagnosis and to manage patients, to monitor patients. Recently, there's been an international group that has brought together recommendations for the diagnosis and management of patients with adrenal leukodystrophy. You can access this scientific medical publication freely from the internet. A group of us collaborated together to bring together really the best consensus-based views on all of these areas. Now, this is not a definitive final document, but I think it's very helpful and gives a good framework for the monitoring that we should be undertaking. And this next picture is a table that just illustrates the different areas that we need to be screening or monitoring for in someone who has ALD. And it splits into males at the top, because we know that males are much more severely affected than females. And so there's a bigger list of things that need to be monitored for males with the condition, including for cerebral ALD, that's the brain disease, for myeloneuropathy, that's the spinal cord problems associated with the condition, the adrenal insufficiency, so the endocrine hormone problems, as well as gonadal insufficiency, all to do with pubertal development. And we'll talk through some of those in a moment and the different schedule. So if someone has been diagnosed with ALD, so for a boy with ALD, one of the big areas that we need to look for is the adrenal glands, the endocrine problems. So if we've made the diagnosis, you would have baseline testing to see whether there's any adrenal problems, and then regular monitoring, at least on an annual basis and maybe more frequently depending on the situation. That would be in conjunction with an endocrinologist, someone who has expertise in the monitoring of the adrenal function tests. And if that did pick up a problem, you would then start adrenal replacement therapy, so regular adrenal hormones, and having in place appropriate medical alerts to let healthcare professionals know about that problem in case you are unwell. So that's a very important part of the monitoring that would carry on for someone who has the diagnosis of ALD from the diagnosis and continuing forward. In terms of the brain disease, and this is really the focus of what we want to talk about in this session, we know that for males and for boys in particular, that there is a risk of developing what's called cerebral ALD, where the brain is affected by the leukodystrophy. Leukodystrophy simply means abnormality of the white matter of the brain. Now, this affects about 1 in 3 boys with ALD. And if that starts off, there can then be very rapid changes and rapid deterioration. And it's a very severe condition if that occurs. We know that without treatment, that will continue to deteriorate very, very rapidly and can be life-limiting. We also know that there are disease-modifying treatments that can stop the progression of the cerebral ALD if we can catch it early. And those treatment options include hematopoietic stem cell or bone marrow transplant. Some of you will be aware of the gene therapy transplant option that has been developed, although not currently available here. These are 2 treatment options that can stop the disease progressing, but they're not suitable if you've already got advanced brain disease, if the disease is already so far progressed, because we know that it can't reverse it, it can't stop it, and in fact may make it worse in that situation. And it's also not appropriate for us to treat the 2/3 of boys who are not going to get the cerebral ALD. It's not something we can offer and give you that treatment so it prevents it happening in the future. We can only do it at the point that it's occurred. And so that's the reason why we need this very close monitoring to spot the early signs of brain disease. Now, clearly, again, going back to our roots into diagnosis, when the diagnosis is made of ALD, there'll be an initial baseline assessment of whether there is any brain disease. Now, for some boys, they may have presented because of the brain disease, and that was the first thing that's brought them to medical attention. And a first brain scan may already show advanced brain disease, where it's already very far progressed. In that situation, where those disease-modifying treatments are not considered suitable, the management is going to very much focus on the symptomatic treatment options. If we make the diagnosis, either because of some neurological problems or because you've had an adrenal crisis and the brain scan, the baseline shows early brain disease, then we've got the option to consider those disease-modifying treatments. And then if you've had the diagnosis reached either because of adrenal problems or because of family testing and so on, and your baseline brain scan shows that there's no brain disease, that's where we then move into the monitoring phase, where you would have regular brain scans that may continue to show no brain disease. And so we would carry on monitoring every 6 months to start off with, and once you turn 12, every year, to look for any evidence of brain disease. And if those scans then did show evidence of early brain disease, we would move into considering the disease-modifying treatment options. And there are different ways that we assess the brain disease. As we've said, the clinical assessment is part of that. And there is a score called the neurologic function score, which is important in assessing some of the major problems that the brain disease can cause. And so our assessments will include talking about the problems that you're having, neurological examination, and also regularly evaluating in the clinic if any of these problems are being developed. And if you develop any new symptoms, that will prompt an urgent re-evaluation, so a change in behavioral patterns, a decline in cognitive function, school being worried about academic performance changing, or if there are physical neurological problems, then that will prompt a re-evaluation. And so that score can help us to assess how far progressed that brain disease might be. The brain scan monitoring, we've already said, this is based on those international recommendations, is that you would have an MRI scan every 6 months from 2 to 12 years, and then annually after that. If you develop any new symptoms, an earlier scan may be undertaken. And if an MRI scan showed very minor abnormalities, you might then repeat it after just 2 or 3 months to evaluate what's going on. And if, as we've said, if it's showing evidence of brain disease, we would then be considering those disease-modifying treatments. We do this every 6 months to start with, because we know that the most at-risk period are those early years of childhood. Once you turn 12, the risk decreases of the development of the cerebral disease, which is why we're then doing the assessments less frequently. You will have heard probably of the Loeys score. This is a measure that is used to assess on the brain scan how much of the brain is affected by the changes, and it ranges from 0, where there's no disease, to 34, and the score is completed by the radiology doctors who look at the scans to assess which parts of the brain are affected by the condition. And that also can help us understand, in conjunction with all of the other assessments, how far advanced the disease is. So these are some pictures from some brain scans. These are slices looking top down through the brain. And in this scan, there are some very subtle, very early changes at the back of the brain, which have been monitored closely and have got a little bit worse and led on to treatment for this child with a bone marrow transplant. Even after transplant, there was a little bit of further change, but then it stabilized and stopped progressing further. So that's early cerebral disease. Sometimes, though, the scan will show what we call later advanced cerebral disease. What we're seeing in these scans, again, cross sections looking down, is these very prominent, brightly colored white areas that are affecting the back of the brain, but also spreading far forward, suggests that the disease is very progressed already. And that's important, as we've already said, because we know that things like bone marrow transplant are effective at halting the disease if you have early brain disease, but it's not effective if you have advanced disease already. There are very significant risks and side effects with the transplant, and so we would only want to put somebody through that if we thought there was a good chance that it would be able to stop the disease progressing. There is not a black and white cutoff. However, the recommendations are that if you have a brain scan with a low score of 10 or more, that would suggest the disease is already very advanced. And if the neurologic function score is more than 1 or 2 points on the score, that's also suggestive that the condition is very advanced. Where it's not clear, there would be important discussions between family and the doctors involved to decide what would be the best treatment options. Just one slide. I was asked just to mention current situation regarding Lorenzo's oil. You'll have heard of Lorenzo's oil and be familiar with this. Some of you may indeed be on treatment with this. This is a special mixture of fatty acids that is used in conjunction with a low-fat diet as an attempt to lower the very long-chain fatty acids, which we know are high in patients with adrenoleukodystrophy, aiming to prevent the onset of the brain disease. There's been a lot of debate and a lot of work looking at this over the years. The current situation is that there is, in medical research terms, insufficient evidence that Lorenzo's oil provides clinical benefit in preventing the onset or the progression of the brain disease. And the current international recommendations reflect that the data to support the efficacy of that as a disease-modifying treatment is insufficient. Now, there are still some views that this may be helpful, and if this is a treatment that you want to discuss, it would be something to discuss with your clinical team directly. There are other approaches to trying to lower the very long chain fatty acids down. There are some newer versions of Lorenzo's oil that have been developed. There are other medications that aim to change that as well. But all of these are still very much experimental and would not be in the mainstream. So that was just a comment about the current position with Lorenzo's oil and why this is not routinely recommended for everybody at this stage. So we'll wrap up there. I hope that's been helpful in just illustrating the importance of monitoring as we're tracking the progress of the condition, thinking about those early warning systems, looking out for those early signs of brain disease where we can, so that we can step in with timely interventions, both symptomatic treatments to make sure we're dealing with the problems that you're experiencing, but also considering those disease modifying treatments. Thank you for your time.